Thank you. We'll move on to the next speaker, Dr. Shweta, who is going to speak to us on ocular surface disease in pediatric population. She's a senior cornea specialist at Shankar Nethralaya and is doing great work.
Thank you so much, and thank you all for being here at the last session. So it's good to see, audience for us. So I'll take you through the spectrum of the pediatric ocular surface conditions that we have and that we usually encounter. Now, what do we mean by ocular surface disorder? So a disorder which involves any component of the ocular surface. So that starts from your eyelids to your eyelashes, to the conjunctiva, to your fornix, to the cornea and the limbus, along with your blink. Now, the ocular surface disorders for children can be based on the etiology. That is, it could be immune-mediated, that is lid margin, allergies, Stevens-Johnson syndrome are the most common ones that we see. Trauma, chemical or firecracker injury. Tumors, again, are extremely rare, usually found most commonly in XP patients. Congenital, that is alacrimia, aniridia, dermoid, or it could be infective, that is post-conjunctivitis or trachoma. Now I'm going to take you through the most common ones that we encounter in the clinic. Now let's start with the immune-mediated, the lid margin. So very commonly you will see patients who come to us with complaints of photophobia, recurrent redness, or recurrent bulge in the lids where it's a chalazion or a sty that we see. And on careful examination, sometimes they just have these cheesy noodle-like secretions when you try to milk the meibomian glands. They could also be associated with a systemic disorder like an epidermolysis bullosa, where they have a less of alopecia component also contributing to it. They often present with peripheral limbal infiltrates or marginal keratitis or even flictans. Most often, these patients are diagnosed or misdiagnosed as allergic conjunctivitis because very rarely, what clinicians miss out here is there is more of redness than itching. But when a child presents to you with redness and itching, the first diagnosis that most clinicians label them as is an allergic conjunctivitis. But we need to check for corneal flictin, staining of the cornea, and I believe the most important question that we need to ask the parents is it redness which is bothering them more, or is it the itching? If it is redness, we know that we are dealing with lid margin, and if it's itching, then it is the allergic component. The lid margin related disorder could be also related to a systemic condition that we just saw one of them, skin, eczema, atopic dermatitis, and what they need is a lid hygiene, lubricants along with anti-inflammatory like your topical cyclosporin 0.05%, and sometimes in the severe cases, you might also have to do a regular milking of the glands. And if they cooperate a little elder, ones can be taken up for the IPL treatment as well. Moving on, VKC or vernal keratoconjunctivitis is again a very common form of allergic keratoconjunctivitis that we see, wherein patients present with a conjunctival pigmentation. In the acute stage or in the stage of activity, they will present with Horner-Tarntras dots, which are these raised eosinophilic deposits that you see around the limbus. In more complicated cases, they might present to us with a shield ulcer, which are sterile ulcers with immune deposits on it. Could be most commonly because of the mechanical component of the giant cobblestone papillae on the tarsal plate, or it could be just the inflammatory epitheliotoxic mediators released from the limbal papillae. Now, in these patients, if the disease progresses, then it can result in disease-related complications like keratoconus and limbal stem cell deficiency. This is the recently proposed universal grading of vernal keratoconjunctivitis that has been published now in British Journal of Ophthalmology, where we have graded, have taken into account not just the disease activity, but also the corneal telltale signs and the complications of the disease, which was lacking in the earlier classifications. So the grade 1 here is mild seasonal symptoms with or without signs. Moderate are persistent symptoms with or without signs, with no corneal involvement. Severe ones, the symptoms become more chronic and persistent, or they could be intermittent signs with corneal involvement. The patient could also be asymptomatic and just have some telltale signs of corneal involvement, like a corneal scar, indicating an old healed shield ulcer. The very severe ones have these chronic persistent symptoms with corneal telltale signs or an active involvement, or they could just be asymptomatic with the complications that we just saw, like a keratoconus or a limbal stem cell deficiency. Whereas the treatment guidelines are concerned, the grading also proposes a treatment guideline where we can use the dual-acting anti-allergics in the milder stage. Once it starts becoming persistent, we advise a referral to an allergy specialist because there is sometimes an ongoing systemic allergy component which is contributing to the severity of the disease. In these cases, let the patients continue on the perennial dual-acting anti-allergics with on and off low-dose topical steroids during the active phase. When it becomes severe, you would need all of the above along with the topical immunomodulator and surgical intervention wherever required, like for giant papillae or shield ulcer. In the very severe categories, we might have to step up the concentration of the topical immunomodulator like tacrolimus or cyclosporin to the maximum available in your zone. Pulse, high-dose topical steroids, or sometimes even short course of oral steroids might be required. Surgical intervention for associated complications wherever indicated. Now, atopic keratoconjunctivitis is again something which is a severe version, and without a referral to the dermatologist, only treating the ocular component will really not help, like was in this patient who presented to us with bilateral total limbal stem cell deficiency with right eye having an ectropion because of the severe scarring induced by atopic keratoconjunctivitis. Now, moving on to the next condition, that is Stevens-Johnson syndrome. Patients or children often present with severe dryness, like was in this patient. He had a severe dry eye with an epithelial defect and just a punctal cautery which will help retain the tears that is there on the surface, facilitated epithelialization of that defect and quietened the eye. The patient was continued on topical lubricants post-which. The lid margin keratinization is another common complication associated with Stevens-Johnson syndrome, and what it results is causes a blink-related microtrauma. With every blink, it goes and causes a mechanical rubbing of the corneal surface, resulting in superficial punctate keratitis, and in chronic stages, vascularization, limbal stem cell deficiency, and corneal scarring. Now, what we need to do is, the minute you see patients with superficial punctate keratitis corresponding to the areas of lid margin keratinization or a corneal vascularization, it's better to go ahead with excision of the keratinized lid margin along with a mucous membrane graft. Sometimes you have children who present to you with just a keratinized surface with some amount of corneal scarring. Now, the keratoprosthesis is not an option for the pediatric age group, but in these kind of situations, a Boston or a Prose lens does really well, and it does help improve the vision of the patient. Moving on to trauma. Now, chemical injury or Lyme injury is something that we very commonly see in our continent, and if there is presence of any foreign body, it needs to be removed. Like was done for this child, a Lyme plaque was found retained in the superior bulbar surface as well as the cornea, and a surgical excision was done for the same, following which the eye has quietened down and the child is maintaining vision of 6/12. Firecracker injury is again something which is very commonly seen in the acute stage. The child presents to us with lid edema, scleral ischemia, and with or without large epithelial defects. The initial stage examination becomes difficult because of the lid edema. Placing the speculum becomes difficult. So sometimes lid sutures might be required to aid in a proper exposure. Always a general anesthesia examination under anesthesia is recommended because you would have some debris stuck somewhere which needs to be removed. This child was taken up for a tenonplasty and an amniotic membrane transplant, following which the surface epithelialized like is seen in the lower pictures. Now, management of the acute phase is all about the eyes and the E's. The eye is your inflammation, your ischemia, and your intraocular pressure, which needs to be taken care of. And your E is your epithelial defect and exposure, which requires the epithelial defect will benefit by using a BCL, a bandage contact lens, an amniotic transplant, or an alloslet wherever indicated. Inflammation would be topical steroids. Ischemia, a scleral ischemia, like was done in the earlier patient, a tenonplasty. If there is an exposure, especially seen with thermal injuries, where the lid blink becomes inadequate, you will need a tarsorrhaphy, and a note of the intraocular pressure becomes important. Moving on, in the chronic phase of chemical injury, you will often have children presenting to you with a symblepharon or a partial limbal stem cell deficiency, like was in this patient, wherein he underwent a symblepharon release with just a conjunctival autograft and an amniotic. If you look very carefully, almost 10 clock hours of the limbus is intact. So you really don't need a limbal stem cell transplant in this. It can be treated just like a pterygium surgery, but requiring a little more extensive release of the tissue. This patient, a case of a total limbal stem cell deficiency following a chemical injury, did well with a simple limbal epithelial transplant with vision improving over a period of time. Now, sometimes these children also present to you with penetrating injury, and Jaya had taken us through the entire spectrum of corneal trauma. This was a child who presented to us with a large cyst. She was around 14-15 years of age. It is a non-seeing eye, and she was keen for cosmesis. We went ahead, realized that that large cyst had some amount of scleral thinning, corneoscleral thinning, for which a corneal patch graft was done. And this is how she was post-operatively and is awaiting a cosmetic contact lens. Moving on to the congenital category, where we have dermoid. The main indication for dermoid is the corneal astigmatism that it causes. So if there is a significant corneal astigmatism, we would advise the patients to go ahead for an early surgical intervention. However, if it is not, if it is only cosmetic, then probably they can wait a little longer to avoid GA-related complications in a younger age group. This child underwent a dermoid excision along with an amniotic membrane graft, and he was a child of golden hour syndrome. Aniridia is another congenital problem that we often see in children, most commonly associated with patients complaining of photophobia, having limbal stem cell deficiency and secondary glaucoma. If the limbal stem cell deficiency is not very severe and the child is still maintaining vision, just giving them lubricants or an anti-inflammatory like tacrolimus to take care of that subtle inflammation to prevent further stem cell loss can help. If it is a severe stage, a PROS or a Boston scleral lens does well in these category of patients. Moving on to the infective, well, Dr. Sumana has taken us through the entire spectrum, but just the post-adenoviral keratoconjunctivitis, often children present with these nummular keratitis lesions that affect their vision, where they cause blurring of vision and photophobia. Very rarely, they can also present with a severe dry eye, which occurs because of this conjunctival scarring that we see in these patients. A punctal cautery in this severe category often helps, and continuing tapering of topical steroids along with adding them on topical cyclosporin will take care of the nummular keratitis lesion most of the times, very rarely requiring PTK. To summarize, wide spectrum of ocular surface disorders is seen in the pediatric age group. You need to have a careful evaluation along with a detailed history to actually clinch the diagnosis, and a tailored and collaborative approach will help improve our outcomes. Thank you so much.
Thank you, Dr. Shweta.